I have the very exciting topic to lead off with on thromboembolic complications in bladder cancer, so please try to stay awake because it gets a lot of interest. So this is try to make it a little bit more interesting on blood clots and understand that some people like Dennis Farina and Gary Shandling, I didn't know that, died of blood clots. Jimmy Stewart died of a blood clot. And then we have other people such as very famous athletes and NASCAR drivers who have blood clots and have had to modify a lot of their schedules. So this is a real problem. And obviously in our patient population, it's a much bigger problem. So as has been alluded to in the last panel, radical cystectomy is probably one of the more difficult, challenging, and complex operations that is done in medicine. I think people underestimate the fact that it's an extirpated procedure, it's a reconstructive procedure, and it violates two organ systems. And there's very few procedures in medicine that have that background in really opening the door to a lot of complications. So major complications up at 13%, overall 65%, frightening 90-day mortality of up to 4%, and basically based on your Clavin grade, as that goes up significantly, so does the incidence of complications. What about readmissions? I believe Dr. Cookson was responsible for this paper, Dr. Cookson? So we might ask you questions about it. They did a study that was published back in the Journal of Urology that looked at readmissions within 90 days. That was 26%, and another 20% within 30 days. Most common diagnosis within 30 days were ileus, pyelo, urinary tract infection, and venous thrombosis. The most common diagnosis up to 90 days was pyelo and obstruction of the urinary tract. Predictors of readmissions were higher Charlson comorbidity index and any patient who had any type of postoperative complication. So these implications of these adverse events and the length of stay was looked at by Steve Bajoran and the team up at the Mayo Clinic, and they look at the national inpatient data set and looked at a lot of the hospital-acquired adverse events. And when they ran down the list, the highest risk was associated with infection and deep venous thrombosis that added an incremental cost on this particular group of patients of about $44 million. So this is not only is the morbidity, but also high cost involved with this complication. The sad thing is, from the NISQIP data set from 2010 to 2015, we really haven't done much better. Gary Steinberg did this analysis about a year and a half ago, and basically over the last 5 to 6 years, we've really not seen a lot of change in the severity and the readmission rate at 30 days. So it just underlies the fact that this is a tough operation with a lot of potential complications. This has just been talked about a couple of minutes ago, the RAZOR trial, which is a large 15-center trial randomizing to open or robotic cystectomy. All of the cystectomy patients had an open urinary diversion, and really there was not a lot of improvement, to be quite honest, as was been previously noted, but I'm just highlighting here on the fact that the pulmonary embolum rates and the thromboembolism between the open cystectomy and the robotic procedure were pretty much similar. So the robotic cystectomy really didn't help us a lot in that regard. So looking at the overall complication rates, avoid the preventable hospital-acquired adverse events, reducing blood transfusion, improving perioperative antibiotics. But one of the tricks that we really need to do, and I think most of us do this now, is extend the perioperative deep venous thrombosis to beyond the discharge and send patients home on Lovenox. So ERAS protocols were just mentioned, and I think the ERAS protocols look good on paper, but when you actually do a deep dive on them, they're not really bringing us all the benefits that we thought they might bring. So Sia Dashman out in California did this enhanced recovery protocol at the radical cystectomy and basically showed no significant difference on his hands using his ERAS protocol. 30-day readmission rate was fairly similar, and again, their findings were consistent with all the complications associated with traditional radical cystectomy. Here, Sam Chang looked at a overview, a meta-analysis of ERAS versus standard of care. And when you looked at the meta-analysis, particularly from the 30-day standpoint, most of the countries out of the United States did a little bit better. When you came down to 90 days, you started to see that there was no benefit in the ERAS protocol. And again, if you look at where this forest plot ends up, it really kind of sits on the line, suggesting that there's a lot of enthusiasm for the ERAS protocols. There's a lot of work that goes into them, but they still have not yielded us the benefit, particularly when it comes to the perioperative venous thrombosis. So when we talk about radical cystectomy, venous thromboembolic events include both DVT and pulmonary embolism within 30 days of a radical cystectomy, are anywhere from 6 to 10%, depending on which paper you look. It usually is after discharge, as we noted that they are diagnosed. And again, high mortality, about 7% of patients who have a venous thromboembolic event will die. And again, we mentioned earlier, high cost. A PE costs $14,000, and a DVT costs an additional $7,500. Why does this happen with bladder cancer? There's a lot of reasons, and that fact is urothelial carcinoma is very thrombogenic. It has factors that induce hypercoagulability. A lot of our patients are older. A lot of patients have a long history of smoking, which gave them the bladder cancer in the first place. That sets them up for hypercoagulability. And there's other fact that in the pelvis, we're doing a lot of work on veins and pushing on veins and retracting on veins, and that can cause some problems. Systemic chemotherapy has been shown to increase the risk of thromboembolic phenomenon. And lastly, we're doing more imaging, cross-sectional imaging, and we're doing a lot more imaging of patients' lower extremities when they have a little bit of swelling. Most of the time, it's just from some edema, but we're picking up a lot more subclinical venous thrombosis than we ever did before. So there may be some factors involved with us looking for things and finding them, and they may or not be clinically significant. Now, this was a NSQIP database review. And it looks at patients undergoing cancer operations in general. And this is a whole bunch of cancer operations. And in our world, we can see here cystectomy, nephrectomy, and prostatectomy. Surprisingly, prostatectomy was quite low. But when you look at who has the highest rates, esophagectomy and cystectomy comes to the top when it comes to deep venous thrombosis. When you look now at PE, it's really startling the fact that cystectomy pops to the top, even more than esophagectomy, pancreatectomy, and other hepatectomy, other more invasive operations. Again, underlying the fact that radical cystectomy is a big, ugly, complicated operation. And lastly, overall venous thrombosis complications, taking everything into account, PE, DVT, esophagectomy beats us, but unfortunately we're still up there fairly high at about 5%. Now this is all cancer operations specifically. So if you look at procedure-specific risk of this in urologic cancer surgery across the board, you can model certain patients into risk characteristics for thromboembolism. Whether or not we have been able to modify this is not really clear, but one very interesting thing to me that I was kind of surprised about is venous thrombosis in a first-degree relative, a parent, a full sibling, or a child, actually doubles your risk of having a venous thrombosis. And of course, a prior venous event or patients with any combination of two of these more risk factors up here, older age, obesity, also leads to a risk. So basically, if you look at our urologic cancer patients, they're about 3%, 6%, and 12% among low, intermediate, and high risk respectively. Interestingly, it does not appear that our use of perioperative anticoagulation strategies increases bleeding significantly. So how do you decrease the risk of these venous thrombosis events? Well, there's perioperative approaches. Chemoprophylaxis is very common. Sub-Q heparin is considered to be a standard, and it's been around for many, many years. Compression boots are underappreciated, but something very important. And again, you've got to put these on in the operating room at the start of the procedure. getting patients out of bed and having them ambulate. And one of the big things that we've come to recognize over the last few years is the issue of post-discharge prophylaxis, since many of these are diagnosed in the postoperative period. So again, we mentioned that most of the radical cystectomy patients fall into the moderate or high-risk categories that we just spoke about, and those based on the American College of Chest Physicians clinical practice guidelines. And it's clear that the benefits of treating VTE or preventing it prophylactically outweigh the risks, such as increasing bleeding. So what are our options for parenteral anticoagulation? Basically, we use either heparin or low molecular weight heparins, and basically the half-life of heparin is about 1.5 hours, and the typical prophylaxis for the average adult is 500 units sub-Q either 2 or 3 times a day. Low molecular weight heparins have to be reduced if there's renal insufficiency, but the typical dose, it's dosed on a milligram per kilogram basis, but in general, a standard dose is somewhere between 30 and 40 milligrams every 12 hours, and daily if the creatinine clearance is less than 30. Most of us use heparin in the hospital, and when the patient's getting ready to go home or as they're approaching discharge, flip them over to the low molecular weight heparin. So how long should we treat these people to try to prevent the prophylaxis? And there was a very large trial of all cancer patients known as the Enoxacan 2 trial that looked at the treatment of how long you should prophylax someone with enoxaparin, and they were able to show that if you continued patients at least 10 days postoperatively and up to 21 days in a group of patients, that you can decrease the outcome of postoperative venous thrombosis from 12% down to 4.8%. And again, they did not notice in this particular trial an increase in any complications. What about our cystectomy patients? Again, this was a Mayo Clinic study where they started an extended duration thromboembolic prophylaxis and published this in Urology Practice about 2 years ago. They treated them with Lovenox 40 milligrams sub-Q for up to 30 days after discharge, after radical prostatectomy, and they were able to get that DVT rate down to one of the lowest reported in the literature, around 2%. It was 6%, again, in the 6%, 10% range, who did not get the extended prophylaxis. And a relative risk reduction of almost 70% was quite impressive. Large study was done by the team up in New York looking at the venous thromboembolism after all major oncologic surgery, 28,000 operations, and again, over half the PE occurred after discharge. When you look at the radical cystectomy, again, you will see the rates are as we would expect. Whether they were open or minimally invasive surgical procedures, they did not show a major difference. So again, another evaluation done by the team out on the West Coast, looking at NISQIP data. Again, 6% overall interest in clinical venous thrombosis. Again, the median time was 14 days, and again, over 55% were diagnosed after discharge. And again, 7% mortality if diagnosed with a venous thromboembolic event. They were able to show that most of these, again, occurred somewhere between 14 and 30 days, underscoring the fact that we need to send these patients home on extended prophylaxis. Again, this trial, looking at overall, this trial showed about a 12 to 4% reduction in all patients using enoxaparin, and again, DVTs went down from 1.8% to 6%. Bleeding was not really a major problem using the Lovenox in this particular trial. So should we go longer than 4 weeks is the question. Some believe that it should be up to 30 to 90 days after surgery. Again, not really clear, but the literature basically agrees right now. Usually at least 30 days is appropriate. Some groups have already changed their approaches. University of Chicago with Gary Steinberg now use the extended duration prophylaxis, as do the team up at the University of Minnesota using the extended venous thrombosis at 90 days, they went from 18% down to 5% with no increase in bleeding. The cost, no patients had to be readmitted in the one study for bleeding complications, and no difference in the rate of systematic lymphocyl. That was something we used to worry about a lot in radical prostatectomy. Other issues of thrombosis, you can get arterial thromboembolism. We tend not to talk about it, but it is either defined as NMA or an ischemic stroke. And again, this is also due to the hypercoagulability, something that we don't talk much about. Another thing that we don't talk much about is patients who get neoadjuvant therapy are increased at risk for venous thrombosis and need to be considered for aggressive DVT prophylaxis. What is the American College of Chest Physicians and ASCO? Basically, even though the risk of patients getting chemotherapy induced DVT is increased before radical cystectomy, they don't recommend using prophylaxis while they're getting the chemotherapy, just recommend it when they start the surgery. So again, we got a lot of complications here in radical cystectomy. It's already been mentioned that the high volume facilities, in some studies even more than high volume surgeons, improve the outcome. The only thing that the enhanced recovery has been shown to work well at was improving GI complications. Robotic procedures may not improve the overall complication rates. This has been mentioned, the prehabilitation exercise and immunonutrition, and we should try to reduce and avoid preventable events. Blood transfusions, one of the big benefits of the robot is decreasing the transfusion, and there's other strategies that are out there. So venous thromboembolism occurs with significant frequency, probably somewhere around 6 to 7%. A lot of morbidity, costs associated with it, but it can be favorably modified through the extended use of low molecular weight heparin, and again, at no increase in bleeding or lymphocyl formation. And there's a grand rounds in urology out there by Jonathan Pintas, who, if you want more details on this, is available.